Hi, I'm Viet Le, an Associate Professor of Research and a Preventive Cardiology PA at Intermountain Health in Salt Lake City. Thanks for joining me for the second video in my Vital Round series about cardiovascular kidney metabolic syndrome, or CKM. In this video, we're going to talk a little bit about pathophysiology to understand why some screening assessments are so important. There is a bidirectional relationship between the kidney and the heart, which should prevent us from thinking about kidney and cardiovascular health separately. In fact, there are four main mechanisms at the core of CKM that impact the heart, the kidneys, and metabolic function. These are inflammation and oxidative stress, insulin resistance and hyperglycemia, dysfunctional adipose tissue, and neurohormonal activation, including the renin-angiotensin-aldosterone system and sympathetic nervous system. When these mechanisms are at play, we see several blood and urine markers change, and some can indicate subclinical changes and the need for action. Let's talk about a few of them. Early stage CKD doesn't often cause symptoms, and if we don't catch it early and treat, it can have a significant impact on cardiovascular health. eGFR, or estimated glomerular filtration rate, can help with early detection. It is a measure of kidney function that is done with some regularity in primary care. We estimate glomerular filtration rate using serum creatinine and cystatin C levels. Reduced eGFR is a predictor of cardiovascular disease. We should be ordering eGFR testing at least every 5 years in CKM stage 0 and every 2 to 3 years in stage 1. When a patient hits CKM stage 2, we should be ordering it at least once a year and also after therapy initiation or titration to optimize cardio-kidney risk reduction. UACR, or urine albumin to creatinine ratio, is another important marker for us as we consider cardiovascular and kidney health. This one is not currently calculated or documented as often as eGFR, but it can be very important for assessing cardiovascular risk. When we think of albumin in the urine, we typically assume it is strictly an issue of kidney function, but atherosclerotic cardiovascular disease and metabolic dysfunction can also contribute to albuminuria. So when we think of a test like UACR, it truly is a unifying marker of cardiovascular, kidney, and metabolic health. In fact, even values that fall within the traditionally normal range may still carry important cardiovascular risk information. One practical point. Most EMRs allow you to simply order a UACR directly rather than calculating it manually. For patients in CKM stages 0 and 1, this test isn't routinely indicated. But once a patient reaches CKM stage 2, we should order it annually. KDIGO guidelines rely on a combination of albuminuria and GFR to determine risk related to CKD. And the American Heart Association's Prevent Calculator has incorporated both eGFR and UACR into their calculations of cardiovascular disease risk. I use the Prevent Calculator with all of my patients in stages 0 through 2. It tells me their risk of cardiovascular disease, atherosclerotic cardiovascular disease, and heart failure. To use the calculator, you will need several characteristics and results that you most likely already have for your patients, including systolic blood pressure, total cholesterol, HDL cholesterol, eGFR, BMI, history of diabetes, current smoking habits, and whether they use lipid-lowering or antihypertensive medications. The calculator can be run with these metrics alone, but you can also add values for UACR, HbA1c, and the patient's zip code. These allow for further personalized risk assessment and are worth adding if you have them or they are clinically indicated. Before we finish up this video, I want to talk about specific screening for heart failure. As patients proceed from stage 2 to stage 3 CKM, we really should be using natriuretic peptides like BNP or NT-proBNP as cardiac biomarkers that can detect heart failure. A recent real-world evidence study confirmed that increased NT-proBNP is highly prognostic of future risk for heart failure and mortality in those with diabetes even before symptomatic heart failure develops. This is really important because it allows us to recommend more intensive cardiovascular disease prevention strategies, including both lifestyle and guideline-directed medical therapies. So, if you take one thing away from this video, I hope it's that we have powerful biomarkers and tools that can help us understand cardiovascular risk in our patients with CKM syndrome, and we should use them as recommended to improve the chance of preventing CKM progression and CV disease. Thanks for joining me. I'll see you for my next video where we'll discuss a patient case.